LSVT LOUD does not harm the swallow. It does no harm, but is it an effective swallowing therapy? No.
Hi everyone, and welcome to our third episode on Dysphagia Matters, evidence-based talks with Julia and Jule. Today we are really happy to welcome Cynthia Fox.
Cynthia is the CEO and co-founder of LSVT Global. She began working with Dr. Lorraine Ramick over 20 years ago, conducting efficacy research on LSVT in people with Parkinson's disease. She was the first to apply this treatment to disorders other than Parkinson's disease, such as multiple sclerosis, and pioneered the application to pediatric populations, including children with cerebral palsy and Down syndrome. We could say so much more about her, but I think it's time to welcome her so you can get to know her yourself. Hi, Cynthia. It's so great to have you here.
Hello, and thank you for having me.
Yeah, we're really delighted to have you on the show. And our listeners might be wondering why we have invited Cynthia to talk on our podcast about swallowing and swallowing disorders. If I might reference her, she told us beforehand that she's definitely not a swallowing expert. But what we do know is that she's an expert in speech and voice in people with Parkinson's disease, and that she's an amazing clinician, researcher, and human being. I myself am a certified LSVT LOUD clinician, and I've been working for LSVT Global for over 6 years now, translating their workshops from English to German. And every single time I am impressed by how engaging, passionate, vivid, and motivating Cynthia is, and how much fun she's having when giving these workshops. Within these workshops, and also within the literature, there's quite a discussion and many questions about LSVT LOUD and swallowing in people with Parkinson's disease. So that's why we thought, let's invite Cynthia and ask her anything about the mechanism and impact of LSVT LOUD on swallowing in people with Parkinson's disease. Fortunately, Cynthia agreed to come on the show, and here we are. Some of our listeners might be familiar with LSVT LOUD and some might not. Therefore, Cynthia, would you mind starting our conversation with explaining what LSVT LOUD is?
That is a great place to start. And so thank you again for inviting me and for that very delightful introduction. I appreciate it. Thank you. And I'll just reiterate, as Julia said, I'm not a swallowing expert, but I am an expert in LSVT LOUD and hopefully can provide insights as we go through this conversation today. So let me just give a very brief, like all the way back to the very beginning background and where LSVT came from, and even what LSVT stands for. And it stands for Lee Silverman Voice Treatment. And Lee Silverman was actually a woman with Parkinson's disease, and she was the motivation for the work that Dr. Lorraine Ramick began that today is now known as LSVT or LSVT LOUD. And so the Silverman family, at the time that Dr. Ramick met Mrs. Silverman, one of their expressed wishes was if only we could hear and understand her. And so historically, and this was back in the late 1980s, speech treatment for Parkinson's disease really didn't work. In the literature, it was actually written, it could be considered controversial, changes in the treatment room would disappear on the way to the parking lot. And in fact, the entire sort of rehabilitation space, not just speech, but speech, swallow, physical therapy, occupational therapy, all was very limited for people with Parkinson's disease at that time. So Dr. Ramick began her work at the Lee Silverman Center for Parkinson's disease, and as the treatment developed, it really was named in Mrs. Silverman's honor. To get to the heart of what LSVT LOUD is, I think really focusing on the three essential concepts kind of gets you to the meat of it all. And those concepts are, first of all, the target. And the target was voice. And so Dr. Ramick recognized voice was the primary disorder that people with Parkinson's disease had. Soft, monotone, hoarse, roughness of voice, and inaudibility was really a hallmark of their unintelligibility, that they were so soft it was hard to hear them. And so she really went at treating them with that focus on voice and using vocal loudness as a way to scale up effort and help improve not only audibility, but speech intelligibility. What we recognize now is that targeted voice really targeted the underlying neurophysiological problem of bradykinesia and hypokinesia. So scaled down movement amplitude. And by targeting voice through vocal loudness, we're really overriding that soft voice, that hypokinesia in the system. And that has been a very effective way to treat people with Parkinson's. The second key concept is the mode of delivery, and it's intensive and high effort. Very unique concepts, again, at the time this was started. They're becoming more recognized as essential for treatment of almost any neurological condition. But again, back then, these were very novel concepts. So the treatment is delivered in 1 hour individual treatment sessions, 4 consecutive days a week for 4 consecutive weeks. Within the treatment sessions, patients work hard. This is exercise. So there's lots of repetitions, feedback, many principles of motor learning, neuroplasticity are embedded in the mode of delivery of treatment. And then the third key concept, also, which was a unique concept for speech treatment for Parkinson's, is calibration, and really sensory calibration. So calibration addresses the problems, barriers to generalization. So maybe we can get changes in the treatment room, but they walk out the door and they go away. Why? Well, we know now 3 key reasons: a sensory processing disorder, internal cueing challenges, and neuropsychological changes. So individuals with Parkinson's disease perceive their voice to be louder than listeners perceive it. When we get them louder to what listeners perceive as normal, the person with Parkinson's disease feels like they're talking too loud. So we have to convince them over the course of a month of treatment that what feels and sounds too loud to them is actually within normal limits. With that, we're sort of retraining their internal cue so they know when they go to speak, the right amount of effort and loudness to use to hit that normal loudness level. And then finally, the subtle neuropsychological changes. There are changes in learning, slower thinking. And so having a treatment target that is simple, think loud, redundant, it's one cue, one target, it really helps with learning over time. So those are kind of the core concepts of LSVT LOUD. What's unique as well is the very extensive, over 30 years of research on this one treatment protocol. Multiple randomized controlled trials. There's now 5 published randomized controlled trials and of primary outcome variables, and then 30 to 40 additional studies of secondary outcome variables. And that would be from Dr. Ramig's primary laboratory. Add to that multiple publications from other laboratories, both in the US and around the world. And one last thing I'll say is that, you know, sometimes people think, oh, well, it's a protocol. It's the same for everybody. It's a cookie cutter approach. No one size fits all. And I think that's a misconception of the treatment. So yes, it does have a standardized protocol. That's what allows us to study it, to know what works, the core ingredients. But within that, we are able to personalize therapeutic goals, treatment materials that we work on, functional communication goals to really be individualized. And that allows us to treat very early to actually quite severe Parkinson's disease and still have some successful outcomes.
And if we now look at the physiology or pathophysiology in swallowing in people with maybe severe Parkinson's disease, between 11 and 81% of people with Parkinson's disease experience oropharyngeal dysphagia, depending on the severity of the disease and the assessment tools used. And nearly 50% of people with Parkinson's disease experience aspiration, which might increase the risk of developing aspiration pneumonia. And unfortunately, pneumonia is a leading cause of death in people with Parkinson's disease. So what is so special about dysphagia in Parkinson's disease, and why are these patients at such high risk of developing aspiration pneumonia?
Well, I think one way to think about it is Parkinson's disease in and of itself is very complex disorder. And it has very diffuse pathophysiology. And historically, again, we used to think of it as predominantly a motor disorder due to dopamine deficiency. And our understanding of Parkinson's disease today is that it's a much more complex, much more diffuse. So when we look at how it impacts swallowing, it impacts at multiple levels. And so we can think about the core sensory motor deficits. Again, take that bradykinesia and hypokinesia and apply that to the swallowing mechanism. You've got slower movements, which can affect timing of the airway to close and protect, timing to maintain oral containment, coordination, esophageal opening. The smaller reduced amplitude movements can affect chewing and bolus formation, keeping that food and liquid in the mouth, laryngeal elevation and excursion. And so there's a lot of sensory motor components that really can contribute to the swallowing challenges. But there's also non-motor symptoms of Parkinson's disease that can have an impact. We know many individuals with Parkinson's disease have reflux and gastroparesis. These things can also contribute to things like malnutrition, dehydration, difficulty taking medication. And then I think a layer on top of that we don't talk about as much is really an emotional component. People can have anxiety with the diagnosis of Parkinson's disease about, am I going to lose my ability to eat and swallow? So there can be a lot of fear, even before the swallowing problem exists, people maybe who are just diagnosed. And that can lead to anxiety. There can be embarrassment with eating, either just the act of getting food and drink to the mouth due to tremor, things like that, or the fear of drooling or choking in a social situation. And as we know, eating is it's so much of our enjoyment in life, our social gathering. And anytime there's fear, anxiety, trepidation around that, it can have negative consequences in terms of quality of life. So you put all those together, and it's not, I think, surprising that many people with Parkinson's have challenges with eating and swallowing, and that it's very complex.
Yeah, I think it's so important that you mentioned also the emotional aspects, because as you said, eating is so important in our everyday lives that, most of the times I think we learn about the motor aspects, the sensory aspects, but there's so much more to it in our clinical world that we also have to consider. How often do you see these swallowing difficulties in your patients, or can you tell us if there's a specific moment in the disease progression when this comes up next to voice and speech difficulties?
Yeah, I think, in my personal experience, it sort of matches the literature in terms of what we see. I think in general, there's a sense that maybe swallowing disorders are underreported by people with Parkinson's disease. Part of that is likely due to that same kind of sensory perceptual awareness that we might see in voice and speech may also be there in swallowing. So things may be changing, but the person isn't aware. Do you have problems swallowing? No. And then you dig a little deeper in terms of follow-up questions, and you may uncover that, yes, they do have some coughing or choking while they eat, more than, what a typical person might have, wet gurgly voice you may experience or observe while you're working with them. So the awareness and the prevalence sometimes don't necessarily always match.
Is there any specific time when the patients usually show signs of dysphagia or start maybe complaining about swallowing difficulties?
I don't think the literature is clear on that. I think it can be diverse. And by that, I mean, that the relationship between disease severity and swallowing problems isn't necessarily one-to-one. I think that's true for speech as well. Somebody can really be early stage Parkinson's, and for whatever reason, they have greater voice challenges than someone who maybe be more advanced. With that being said, in general, we do see more in later stages of Parkinson's disease, but I think that's true of every symptom that individuals experience, that with advanced disease, we're going to see more prevalence of speech, voice, swallowing, and cognitive, all those types of symptoms begin to appear. So I guess the take-home message there would be, don't assume they don't have a problem if they're early Parkinson's disease. Be on the lookout for signs, ask those questions. Education can be so important. Again, alleviate that fear and anxiety, and then early intervention, which I know we'll get into treatment as we go through this conversation.
Yes, great. And then, like you said as well, don't stop with the first question. Do you feel you have any swallowing difficulties, but dig deeper and really try to get to the core of the problem, because people might not be aware that they actually have a swallowing problem.
Absolutely.
We now know the basics about swallowing and swallowing disorders and Parkinson's, at least the very fundamental basics, I think, what we need to know for now. And are there any similarities between speech and swallowing in Parkinson's disease?
That's a super question. And I think I'm going to talk through it in sort of a theoretical kind of context and how we can think about this. And I give credit to my colleague and actually one of LSVT Global's co-founders, Dr. David McFarland. I always turn to him to more about thinking about swallowing, as that is certainly one of his areas of expertise. But in terms of pathology, there is a common movement pathology. And in fact, Joanne Robbins stated, rigidity and bradykinesia appear to underlie the volitional speech abnormalities as well as disordered volitional oral stage of swallowing. So those were observations back in the, the 80s. But we can, think of problems in movement scaling and sensory motor integration that characterize both speech and swallowing. So one of the theoretical positions we take is, are there cross-system effects? And we need more data to explore this, but we know, for example, feeding and swallowing and speech and voice share the same anatomical structures. Both require coordinated activity across respiratory, laryngeal, and oral articulator systems. There is at least some degree of shared neural control of these behaviors, and sensory motor integration is crucial for both, as well as Parkinson's disease results in degeneration of these neural systems and networks. So from that perspective, you could, hypothesize that there could be similarities in problems with speech, voice, and swallowing for people with Parkinson's.
That makes a lot of sense. You've already talked about evidence and about research, what has already been done in this field. So can you maybe tell us a bit more about it? What is known about the effect of LSVT LOUD on swallowing in people with Parkinson's disease?
Yeah, and I'll build upon what I was just talking about in terms of our theoretically why we would even think that. And then from there, I'll take us into what we actually know. And so going back to the treatment itself, LSVT LOUD, it's an intensive exercise-based treatment. And we know that these types of treatments can be very effective drivers of neuroplasticity. And really what we've learned from LSVT LOUD, in particular from some of our neuroimaging data, it appears to have this top-down effect on these distributed speech networks. And so theoretically, might that also have some impact on the swallowing networks, but of course, much less is known. We know that LSVT LOUD improves amplitude scaling and sensory motor integration, which results in strong functional outcomes. So there's a potential in terms of impact on swallowing for this positive central impact, again, which is this positive, top-down modulation. But there's also potential from this peripheral perspective. So we're improving vocal fold adduction with voice therapy, and we need that good vocal fold adduction for airway protection. In our voice therapy, we're doing exercises that actually facilitate laryngeal elevation related to voice exercises, but might that have an impact on swallowing? Actually, in speech treatment, you swallow a lot. You're talking a lot. We have water, take sips of water. And so there's just a lot of swallowing that happens.
Like they say, LSVT LOUD is such a healthy treatment because you make the patients drink a lot of water, right?
Right. Which is a hydration, right? Improving general hydration and the practice of swallowing. Also, we found, and I'll talk a little bit more about this, a lot of the improvements, in speech measures, we see improvements in articulatory excursion, in speech intelligibility. So tongue, lip, jaw movements in terms of amplitude may also be improving, which could also potentially have an impact on swallowing. Now, the actual study of LSVT LOUD and swallowing is really very preliminary. The very first study that was published was back in 2000. I now just drew a blank. 2000. Oh gosh. Two. Thank you. Yes, 2002. El Sharkawi and colleagues, and this was actually out in collaboration with the laboratory of Dr. Jerry Logeman. So it was her laboratory, and data that we had collected. Independent video fluoroscopy exams were collected and then sent to her laboratory from patients in our studies who were getting LSVT LOUD. So it was pre-post. This was really a reaction to so many anecdotal reports back to us about after LSVT LOUD patients commenting that they felt they were swallowing better or clinicians making observations about improved swallowing. So this was really just the first look. Let's take a look and see what we see. So it was a small study, 8 individuals, and these individuals had mild swallowing deficits pre-treatment and were predominantly, I believe, in the oral phase of swallowing. And they did video fluoroscopy studies, and what they found was most of the improvements in these individuals were in the oral stage and improvements in swallowing efficiency. So we had some nice pre-post improvements in this kind of pilot group. Now, there were not controls, there were not comparative subjects, and they weren't followed over time. But it gave us a little insight that there was something that changed after LSVT with the swallow. Another study came from a group out of New Zealand, and that was the Miles et al. Study in 2017. They did video fluoro studies, swallowing questionnaire, and cough. And they had 20 subjects and looked at them pre, post, and 6 months, so added a time factor. And most of the subjects, I believe, pre-treatment did not appear to have swallowing disorders, or they were very mild. For those that did have, I think there were 8 subjects who had some swallowing deficits on the perceptual scale pre. 6 improved on that perceptual scale post, 1 stayed the same, and 1 worsened on that particular perceptual scale. They showed some improvements in some of the video fluoroscopic measures and some improvements in cough. So those really are the 2 publications. Just last year, I believe there was another publication out of Japan looking at LSVT and swallow in individuals with atypical Parkinson's and showing some very variable outcomes, again, a very much more challenging disorder. But the take-home message at this time is LSVT LOUD does not harm the swallow. It does no harm, But is it an effective swallowing therapy? No, it's not a swallowing treatment. It's a voice and speech treatment, which may in some subjects have also some ancillary benefits to swallowing, and others it may not. So it's not considered a primary swallowing treatment.
So you basically have already answered my question, but I'm going to say it anyways, because I want to go back to episode 1, where we talked a little bit about the recently published consensus statement on the treatment of dysphagia and Parkinson's disease. And it was published by Antonio Schindler and his colleagues. And I would like to cite them here, as this is one of the most recently published papers we currently have on this topic. So they say, besides the positive impacts that Cynthia just mentioned, LSVT LOUD does not specifically target swallowing function, and it should not be considered as a primary treatment of dysphagia and PD. What are your thoughts on that? You already said that it's not a primary treatment, but what do you think about the targeting of the swallowing function?
Mm-hmm. Yes, and I would completely agree with that statement. What I think is interesting goes back to the theoretical cross-system effects. I still think it's an interesting question to study more, and I think we have a lot more to learn. Looking at better controlled studies, looking at people from the beginning who maybe have more significant swallowing impairments that we can document, to look at changes pre-post. But it may also be more interesting to look at it in terms of an additive effect. So while we may look at LSVT as a treatment alone, perhaps one of the more well-documented swallowing therapies with evidence alone, and then in combination, because I think that combination for some patients could really be an additive benefit going perhaps both ways. And that might be some really exciting future work, because we do, from that theoretical perspective, again, shared neural systems, shared anatomical systems, I think driving effort is what's really interesting about what we do in LOUD. And we know patients will revert to a lower effort level left to their own devices. And so we see that in communication. That's why we have to drive the amplitude, drive the louder voice. Driving effort and swallow might be very interesting as well. And certainly people clinically use cues like swallow hard, swallow big. I've even told patients swallow loud. It's just the whole idea of driving more effort than you think you need to have the same physiological output that you had prior to Parkinson's, as kind of an overriding concept.
Yeah, that's really interesting that you mention combining it.
Yeah, well, and I think that idea of with swallow intervention, any intervention, there has to be that component of feel how that feels, feel that effort, feel, what that's like, so that you're not just training a motor behavior, not really in isolation, but just doing the exercise. You've got to put that exercise in context of the physiological effort and how that feels, so they can walk out the door and be able to achieve that without you there in the room with them.
But would you recommend LSVT LOUD for people with Parkinson's disease and oropharyngeal dysphagia as a treatment approach at all?
So I would not recommend it as a primary swallowing treatment. And I think the way we think about this clinically, and the way we teach this oftentimes in our courses, our webinars, is to evaluate patients and then prioritize your treatment focus. And so there are individuals where we would say, LSVT LOUD really should be the first treatment focus. These may be patients who have either very mild or no perceptible dysphagia symptoms. They have a lack of a history of any bronchopulmonary infections. And so they really truly are presenting predominantly as voice and speech. And sometimes it's those individuals who after treatment say, oh, I feel like I swallow better. So it's their perception of that afterwards. In contrast, There are patients who need dysphagia diagnosis and treatment first. Absolutely. They have dysphagia symptoms that are moderate or severe, perhaps a history of bronchopulmonary infections or ongoing infections. Maybe they're already on dietary limitations. And in that sense, traditional swallowing approaches that are evidence-based for people with Parkinson's, biofeedback, expiratory muscle strength training, those types of approaches, I would tackle that first, then maybe on to the voice and speech. And there are some cases that perhaps you can do it concurrently. That maybe that they've got the voice, they have some dysphagia symptoms, but they're not so severe, and the person can handle the dual intensity of treatments. So it's not that we shorten our LSVT sessions and add swallow treatment to it. They would have full LSVT sessions and either a break perhaps, or maybe immediately back to back, and then a swallow treatment as well. And that's dependent upon the patient and facilities and things like that. So we can kind of triage individuals based upon what is their most presenting symptoms. And then in some cases, it might also come back to that personalized. Maybe it could go either way, but for this person, the fear of swallowing and the fear of eating and all of that is so extreme that it's like, hey, we need to deal with this first. In contrast, it may be that same person needs to keep their job. They're still working full time. They have a vocally dependent job that for them, tackling the voice is the most important thing to do first.
Yeah, thank you. This is, I think, really helpful, especially if we are in the clinical setting, and oftentimes we come across these patients and we have to, like you said, the triage and think about, okay, what am I going to do first, or can I even do it concurrently?
You've mentioned a study from, I think it was Japan. They investigated on the effects of LSVT LOUD in people with atypical Parkinson's disease. Mm-hmm. What is your clinical experience with this? Did you experience anything like specific parts of the approach work better with atypical Parkinson disease patients, or maybe there's something that they struggle more with?
Yeah, and I can speak to that in terms of LSVT LOUD. Certainly for atypical Parkinson's, for sure, early upon diagnosis, come to the speech language pathologist for speech, swallow, language, everything. Get that baseline, and we need to treat early, we need to treat often. Because typically the atypical Parkinson's, progressive supranuclear palsy, multisystem atrophy, they're advancing, or the disease is advancing much more rapidly. So the sooner we can get in there, the better. They also don't respond well to medication or to neurosurgical approaches. So really behavioral intervention is the best treatments we have. Getting early, you can have some pretty good initial outcomes. I've had people upon diagnosis, or even where they're sitting, we don't know if it's going to be atypical because sometimes it's wait and see. So let's do treatment. And they can have very good outcomes, but they can change quite quickly. So I've had the instance where, a person who ends up with idiopathic, somebody not quite sure, we do treatment, 6 months later, the person with idiopathic is still doing great, where the person who ended up with an atypical diagnosis has progressed significantly, and I've got to go back in and do tune-up sessions. And that's where you really see it. If we get them later, yeah, it's more challenging treatment. There is no doubt. It's harder for them to do the effort. They may feel more tired. You just have to do more rest breaks, I think, within treatment. And I think this is true whether you're doing LSVT LOUD or direct swallowing treatment. We've got to be a little more sensitive to that. The simplicity of our instructions is a benefit, the one cue, as well as I think the intensity of treatment is even more essential in atypical. Sometimes that seems counterintuitive. People go, oh, they're more severe, advanced, frail. Should I do less? No, it's important to do sometimes more, but you're doing it in a way that's supportive. And they do actually oftentimes gain some endurance, gain some strength over time across that 1 month of training. But you absolutely have to see them more frequently. You'll do your 1 month, you may do your course of swallow eval. You've got to follow up every 3 months, every 6 months. As the disease progresses, you may almost have like ongoing therapy that happens with these individuals. But the take-home message is you can help. You can give them some improvement. So don't discount them.
Okay, stay optimistic.
Yes.
I like that.
Yeah, even if you're giving them the ability to say 10 functional phrases that their family can understand. So going from completely no communication, I can say these 10 things, or everybody knows the cue. Say that loud, say that again loud. So there's some way to be able to facilitate communication is so valuable in those advanced cases and those atypical Parkinson's.
Yeah, I think that's really interesting, especially possible differences that might exist. I think we don't know enough about that yet. Do you know if there are any plans for future research investigating the effects of LSVT LOUD on swallowing in Parkinson's disease, regardless whether it's atypical or idiopathic?
Yes. And so certainly we have some data from our last randomized controlled trial that we're in the process of analyzing to see. It looked at LSVT LOUD versus a comparative intensive treatment, LSVT Artic, which was basically all the effort went to oral articulation. Enunciate was the cue in speech, as well as untreated patients. So just what happens over time. So there's some data in the hopper to be further analyzed. And I think there's some other groups out there that are looking at LSVT LOUD impact to swallowing. I do think what would be quite interesting is the combined approach and what are the additive effects that may give the best outcomes for speech, voice, and swallowing collectively. And for your listeners, if you're interested in this topic, let's talk and let's think about good studies that we could design to start to piece this apart and better understand how we can help our patients better.
In the introduction, I told our listeners that you have also worked with, for example, children with cerebral palsy and Down syndrome with LSVT LOUD. So these children are also prone to having swallowing difficulties. Have you observed any changes in swallowing for these patients as well?
Beautiful question. We've not studied it systematically yet. I could say that our initial anecdotal impressions would be very similar to what we had in Parkinson's, that for some kids, our parents, they're like, it seems to be a little bit better. There is a study coming out by a group, and now I'm not sure where they're located. Now I want to say, I think it was Australia. And they had published their pre-protocol, and they were exactly looking at a drooling in particular in children with cerebral palsy before and after LSVT LOUD. So what's been published to date was their protocol for what they're doing. Their results have not been published yet. So that will be one, systematic study coming out to start to address that very question.
Oh, great. I'm looking forward to reading that because, of course, the pathophysiology is different to the Parkinson's disease patients. But still, that's interesting.
Yeah, definitely. I think so. I think so for sure. And we have, the other population that we've studied in pediatrics, and in fact, our paper should be published this week, is looking at LSVT LOUD in children with Down syndrome. And so that series, 9 children, a single subject series design is coming out any minute now. So we're super excited about that.
Congratulations already.
Thank you.
Okay, thank you so much for all these information that you shared. Is there anything you would like to add?
Just thank you for inviting me, allowing me to share what I know. And I think for the listeners, it's a very interesting topic. And I think what's exciting when we do, if you are LSVT LOUD certified in doing this, you have such a unique opportunity with your patients because very few health professionals get to spend 16 hours with the patient in 1 month's time. And when we're with them, our focus is very singular on the components of LSVT LOUD. We observe so many more behaviors, and that may be a time that we uncover some swallowing or feeding issues, and we can make that referral, or some cognitive challenges, or challenges for our physical and occupational therapy colleagues. So it's really a unique time for us to have this window into patients' behaviors that go beyond, we do our scope of practice, but it allows us to perhaps help patients get other care that they really need. And I think also any opportunity we have to educate our colleagues, our physio and occupational therapy colleagues. Again, they see the patients a lot, what they should look out for, when they should refer, as well as we talked about getting out to Parkinson groups, dispelling myths, minimizing fear, allowing patients to speak up and say, yeah, maybe I do need this. Maybe I should consider this. So we can be great advocates for them.
That's so true. And thank you so much, Cynthia, for coming on the show. We really appreciate talking to you and having this discussion with you about LSVT LOUD and the impact on swallowing in people with Parkinson's and even other patient populations. So we hope you, our listeners, enjoyed this episode as well. If you would like to get in touch with us and stay informed about upcoming episodes, you can follow us on Instagram at Dysphagia Matters, on Twitter at DysphagiaPcast, or visit our website, dysphagiamatters.org. Thanks so much for listening. Thank you, Cynthia, for coming on the show. Take care, everyone. Bye-bye.
Bye.
Bye.